It's time for another warm-up review. Let's get going. Outline the pathway of converting phenylalanine to epinephrine. The first step is going from phenylalanine to tyrosine. The enzyme phenylalanine hydroxylase is going to add a hydroxyl group. Next, going from tyrosine to dopa, the enzyme tyrosine hydroxylase adds another hydroxyl group. Next, you go from dopa to dopamine, and the enzyme is dopa decarboxylase. This requires vitamin B6, and this is the enzyme inhibited by carbidopa. Next, you go from dopamine to norepinephrine, and then the last step is norepinephrine to epinephrine, which is the enzyme phenylethanolamine N-methyltransferase, or PNMT. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
We began our discussion of heart murmurs with the video on diastolic murmurs. And if somehow you missed that one, I strongly suggest you go back and watch that video first. Now in this video, we're going to review systolic heart murmurs, including aortic stenosis, mitral regurgitation, mitral valve prolapse, tricuspid regurgitation, and VSD. So let's start with aortic stenosis, which is my very favorite valvular heart lesion, which did not sound quite so nerdy until I just said it out loud. Before we look at the phonocardiogram and listen to the murmur, think about this with me. Aortic stenosis causes a systolic murmur, which occurs between S1 and S2. But do you expect the murmur to begin right with S1? No. There's a tiny gap between S1 and the beginning of the murmur during the isovolumetric contraction period.
So S1 is the sound of the mitral valve and the tricuspid valves closing. And right at first, the ventricles are contracting, but the pressure isn't high enough to open the aortic valve and the pulmonic valve yet. So the volume of the ventricles isn't changing, and this is isovolumetric contraction. So even if there is some aortic stenosis, right after S1, the aortic valve is still closed, and there's no blood flowing across it, so there's no murmur right after S1. And then when that pressure gets high enough, it forces the aortic valve open. When the valve opens, you have this ejection click due to those valve leaflets coming to an abrupt stop. In aortic stenosis, the valve leaflets are usually scarred and calcified. That's why they aren't opening fully. That's why you have stenosis. So those calcified leaflets come to an abrupt stop, and it makes this abnormal sound, this ejection click. So you hear S1, then there's an ejection click, and then the murmur starts. And this murmur is sometimes described as a crescendo, decrescendo murmur. Those are musical terms. Crescendo means it gets louder, and then decrescendo means it gets softer. So you hear the murmur start soft after that ejection click, and then it peaks in intensity, and then it decrescendos or gets softer. And it ends at S2 when the valve closed. That ejection click can be difficult to hear, but think about the timing and the location. If you can tell this is a systolic murmur that's loudest in the aortic position, the right second interspace, you should be able to guess that it's aortic stenosis. And there are also some clinical clues that can help you. Not only is the murmur heard at the aortic position, but it's also going to radiate to the carotids. As blood goes from the ventricle through the aortic valve and up into the carotid, it's still going to have turbulent flow all the way up there. So if you put the stethoscope on the carotids, you can hear that systolic murmur. It sounds a lot like a bruit. You can also feel the weak, delayed peripheral pulses, which is kind of what you'd expect. That narrowed stenotic aortic valve is kind of blocking the blood from going into the aorta, and it's reducing the force of each beat. You're not going to perfuse very well because you're not maximizing the blood that can flow through the aortic valve with each contraction. So as a result of this, not only do you feel weak pulses, but the patient could also have syncope. If normally you're able to push a certain volume of blood through, now with stenosis you can't push as much blood through. You're not going to be perfusing the brain like you should be. So if they give you an elderly patient with syncope, at least entertain the possibility of aortic stenosis. Then besides syncope, two other symptoms you should think about with aortic stenosis are angina, or chest pain, and also dyspnea, or shortness of breath. So know those three classic symptoms: syncope, angina, and dyspnea. You don't have to have all three. If you have any one of those in the presence of aortic stenosis, it's a very dangerous situation. It's time to replace that valve. Now, what kinds of things cause aortic stenosis? Well, there are 5 causes of aortic stenosis that I want you to make note of in your study guide. The most common cause is a bicuspid aortic valve. So instead of having a 3-leaflet aortic valve, the patient just has a 2-leaflet valve. We saw that as a potential cause of aortic regurgitation as well. A bicuspid aortic valve is a congenital defect, but it generally doesn't start causing problems until after age 40. So most people with bicuspid aortic valves don't know that they have a problem until they get to age 40 and that abnormal valve starts to become calcified, kind of similar to the calcification you get in your vessels due to atherosclerosis. Only here we're talking about calcification of the valve leaflets. So these patients are born with a bicuspid valve, and then as they age, the valve starts to become calcified. They start having progressive stenosis of that valve, and then they get syncopal episodes or chest pain or other evidence of aortic stenosis. So be aware of that. Then the second most common cause of aortic stenosis is what's called senile calcification or degenerative calcification. So here you have a normal 3-leaflet valve, and that valve becomes calcified. This usually becomes apparent after age 60. It takes longer to become problematic, not because it becomes calcified later, but because the normal valve can naturally just open wider than an abnormal bicuspid valve can. A bicuspid valve is already a little narrowed, and then that senile calcification just becomes symptomatic about 20 years sooner than it was if the valve were normal. So if you have a patient over 60 that develops aortic stenosis, think about senile calcification or degenerative calcification. A third cause of aortic stenosis is chronic rheumatic heart disease. Rheumatic heart disease can cause lots of different murmurs, especially mitral valve lesions. But rheumatic fever can damage the aortic valve as well, and that can lead to aortic stenosis. Another cause of aortic stenosis is you can have a congenital unicuspid aortic valve, just one leaflet. It's much less common than any of the other causes we've just mentioned. And then a fifth cause would be syphilis, because again, tertiary syphilis can affect the aortic root and the aortic valve, just like we saw with aortic regurgitation. So again, the 5 most common causes of aortic stenosis are a congenital bicuspid valve, senile or degenerative calcification, chronic rheumatic valvular disease. So those are the big 3. And then number 4 is unicuspid valve. Number 5 is syphilis, which is very, very rare. Next, let's talk about mitral regurgitation, which is another common systolic murmur. This is a systolic murmur that does begin immediately following S1 with no gap. So what causes the S1 heart sound again? Closure of the mitral and tricuspid valves. So during systole, the mitral valve should be closed and there shouldn't be any blood flow across it. But if the valve doesn't close completely, as the left ventricle contracts and pressure rises, blood is forced back across the mitral valve into the left atrium. So blood regurgitates back across the valve. So this murmur starts immediately after S1, even during isovolumetric contraction, and it continues all the way to S2. So we say that mitral regurg is a holosystolic murmur. It occurs throughout systole. Mitral regurgitation is sometimes described as a high-pitched blowing murmur. That's not nearly as helpful for your exam as the fact that it's a holosystolic murmur. And where do you expect the murmur to be loudest? In the mitral area, which is the 5th intercostal space in the midclavicular line. We sometimes call this the apex of the heart. It's where the pointy end of the heart is located. The opposite end, superior and medial, is sometimes called the base of the heart. It's almost like the heart's a pyramid with a wide base up top and the point of the pyramid down here. Another good clue is that mitral regurg murmurs can radiate to the left axilla. So if you put your stethoscope in the axilla, you might hear the murmur up there too. And we also said that mitral murmurs are better heard when you put the patient in the left lateral decubitus position, lying down on their left side. Mitral regurg is enhanced by maneuvers that increase total peripheral resistance, or afterload. So hand grip will do this, and so will squatting. When you have the patient perform a hand grip or a squat, it compresses all the arteries, and that increases afterload. With increased afterload, there's more pressure for the left ventricle to work against, so it's harder to eject the blood. So if there's more pressure in the left ventricle, more blood in the left ventricle, more blood is going to regurgitate back across the mitral valve, and that regurg murmur will be louder. Now, what are the causes of mitral regurgitation? Well, by far the most common cause is rheumatic heart disease. The valve that's most commonly affected by rheumatic fever is the mitral valve. Endocarditis can also damage the valve and cause some mitral regurgitation. Mitral regurg can be due to ischemic heart disease or left ventricular dilation. If the heart dilates, you can imagine how that might cause some separation between the valve leaflets so that they don't close properly, and that allows blood to leak back through. And then mitral regurg can also be associated with mitral valve prolapse. Now, be aware that mitral prolapse and mitral regurg can occur together, but they don't have to. You can have prolapse without regurgitation. You can also have regurgitation without prolapse. Let's talk about mitral valve prolapse, which is relatively common, but it usually isn't problematic unless there's also some mitral regurgitation associated with it. So what is mitral valve prolapse? Well, you can think of mitral valve prolapse as being a mitral valve with very large, floppy valve leaflets, almost like there's redundant tissue, so that the valve leaflets billow out like a parachute. During systole, the mitral valve is closed, but it's prolapsing back into the left atrium, expanding, 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 and then when the chordae tendineae reach their endpoint, they sort of catch abruptly, and you can hear this mid-systolic click. And then after the click, you may hear a systolic crescendo murmur that increases in intensity as you approach S2. If you have the patient Valsalva, that makes the mid-systolic click happen earlier, and it makes the murmur start slightly earlier. But like most murmurs, the murmur gets slightly softer with Valsalva. So it starts earlier, but it's softer. Let's talk about tricuspid regurgitation. The murmur of tricuspid regurg is very similar to the murmur of mitral regurg because the tricuspid valve is the right-sided equivalent of the mitral valve. So like mitral regurg, tricuspid regurg is a holosystolic murmur, and it's heard loudest in the tricuspid area, in the left lower sternal border, in the fourth or fifth interspace. So it's very important to listen in different areas and decide where the murmur is loudest. The other important distinction is that the murmur of tricuspid regurg is louder with inspiration because of increased right atrial return. Remember, if you hear a murmur that gets louder with inspiration, it's more likely to be a right-sided heart murmur, like a tricuspid murmur. If your murmur gets louder with expiration, it's more likely to be a left-sided murmur, like a mitral murmur. So what causes tricuspid regurgitation? Again, rheumatic heart disease and endocarditis. And what type of patients most likely to have endocarditis of the tricuspid valve? IV drug users. They're injecting drugs, they're contaminating their veins with skin flora, and the bacteria kind of travel to the right side of the heart first. So IV drug users are at increased risk of tricuspid endocarditis, which can cause valve damage and tricuspid regurg. Let's talk about the murmur you hear with a ventricular septal defect, or VSD. Now, this is another type of non-valvular heart murmur. A VSD is a hole in the interventricular septum that allows blood to pass from one side to the other. So what does this murmur sound like? Again, this is a holosystolic murmur, similar to mitral regurg or tricuspid regurg. And it's heard best along the left sternal border, kind of in the tricuspid area. So it could be very difficult to tell a VSD from tricuspid regurg. That's where the clinical scenario comes in. If you see a newborn with this murmur, think about a VSD. If you see an IV drug abuser with this murmur, think about tricuspid regurgitation secondary to endocarditis. To wrap up heart murmurs, I want to do a quick audio quiz. I'm going to give you a short scenario and play you a murmur, and I want you to give me the correct diagnosis. Now, we're going to go through 4 cases, and then I'll give you the answers. Ready? The first one is a 68-year-old woman with a history of rheumatic heart disease and this murmur, which is heard loudest at the apex of the heart. Next one. A tall, thin, 42-year-old man with long extremities and fingers. His blood pressure is 138/56. His head bobs rhythmically when he's sitting still, and you hear this murmur, which is loudest at the left lower sternal border. Next one. A 72-year-old man comes to the ER for syncope, and on exam you hear this murmur at the right upper sternum in the second intercostal space. And the last one. A 49-year-old woman with palpitations and chest pain, and when you roll the patient on her left side and you have her hold her breath with expiration, you hear this murmur at the fifth intercostal space in the midclavicular line. Ready for the answers? The first one was a woman with rheumatic heart disease and a holosystolic murmur in the mitral position. That's mitral regurgitation. The second one was a tall, thin man with long extremities, which means he either plays center in the NBA or perhaps he has Marfan syndrome. Then he has a wide pulse pressure and that head bobbing and an early diastolic decrescendo murmur along the left sternal border. So this is aortic regurgitation. Remember, patients with Marfan syndrome tend to have dilation of the aortic root, which pulls those aortic valve leaflets apart, and that can cause aortic regurg. The third one was an older man with syncope and a diamond-shaped systolic murmur at the aortic position. That's aortic stenosis. And the last one was a woman with a rumbling, late diastolic crescendo murmur, heard best on expiration, which makes you think mitral, And it's heard best in the left lateral decubitus position, which also makes you think mitral. So this is mitral stenosis. These are exactly the kinds of presentations you can expect to see on step 1. So be able to correctly diagnose these valve lesions. You've seen the images in the study guide, and we've also included a composite image showing all the major murmurs together, which you can download below. Now the big table in the end of session quiz is a review of all the murmurs we've been discussing, both systolic murmurs and diastolic murmurs. So I want you to work through the quiz, and then we'll go over the answers. First question, which heart murmur is associated with weak pulses? That's aortic stenosis. Sometimes this finding is called pulsus parvus et tardus, which is Latin for weak and delayed pulses. And then for the enormous table, what pathology is associated with each of the following murmurs? A crescendo, decrescendo systolic murmur heard best in the second to third right interspace close to the sternum. That's aortic stenosis. Early diastolic decrescendo murmur heard best along the left sternal border with blood pressure 160/55 is most likely aortic regurgitation. There's that wide pulse pressure again. The late diastolic decrescendo murmur heard best along the lower left side of the sternum would be tricuspid stenosis. Holosystolic murmur, best heard at the apex and often radiates to the left axilla, is mitral regurgitation. Late systolic murmur, usually preceded by a mid-systolic click, is mitral valve prolapse. A crescendo, decrescendo systolic murmur, heard best at the second or third left interspace close to the sternum, would be pulmonic stenosis. So it's similar to aortic stenosis, but the location is different. Holosystolic murmur, best heard along the left lower sternal border. This could be either tricuspid regurg or a VSD. You really need the clinical scenario to make a more accurate diagnosis. A rumbling late diastolic murmur with an opening snap, heard loudest in the fifth interspace in the midclavicular line, is mitral stenosis. A continuous machine-like murmur occurring both in systole and diastole is a patent ductus arteriosus. So that's it for heart murmurs. I'll see you next time.
Whoa, I seriously need to know when you're going to let me borrow that top. Anyway, so during rounds today, I was presenting this patient with syncope from aortic stenosis, and Dr. Wilkerson was all like, describe his murmur. So I was like, it was a harsh, high-pitched grade 2/6 crescendo, decrescendo, systolic ejection murmur radiating to the carotids. And he was all like, did he have strong pulses? You know, trying to trick me. And I was like, cha, as if. The pulses were weak and delayed, you know, classic pulsus parvus et tardus, dude. My physical exam skills are like seriously legit. So we sent his butt into surgery. The patient, not Dr. Wilkerson. Okay, so when can I borrow that top? Seriously.